So I'll get us started then. This is Tyler Buckner, one of the hematologists at CU, and welcome everyone to the Robert H. Allen Memorial Hematology Symposia for today, February 16th, 2023. Thanks everyone for coming. So today we're going to hear from Dr. Genevieve Moyer. Dr. Moyer did her medical training at St. Louis University, followed by residency in internal medicine and a chief residency at SLU, and then came to the University of Colorado for hematology oncology fellowship, and is now an assistant professor of hematology in our group. She is a general hematologist and sees people with all kinds of non-cancer hematologic diagnoses, but primarily hemostasis and thrombosis, and has a focus particularly on women with bleeding disorders. So excited to hear from Dr. Moyer today. And again, thanks for your attendance.
Thank you, Tyler, and thank you everybody for coming. And I appreciate you listening to that little introduction. This is the second time I've given this talk, and I didn't realize there was quite so many technical difficulties with actually sharing a screen. So what I was trying to really show you is this clip from a movie called The Devil's Violinist. And it's a really beautiful clip, and the relevance will kind of make sense in a minute. But overall, what I'm going to be talking about today is hypermobility disorders and how collagen disorders that cause hypermobility also can cause bleeding symptoms, and why that's a really important thing for hematologists to know about. This is something that I've developed an interest in as a result of working in the Spots and Dots clinic, where we see lots of patients with bleeding of unknown cause. People are presenting with heavy menstrual bleeding or other types of bleeding. When we've been screening these patients for hypermobility, I've just been astonished of how many I find have this hypermobility phenotype. And so it's kind of sent me down this rabbit hole to try to better understand how that relates to abnormal bleeding symptoms. And it's been quite an interesting journey. A lot of the things I'm going to be talking about today are definitely based on very limited data. This is not a really robustly studied topic, and I hope that's something that changes in the future, and that by generating interest and awareness, next time I do this kind of talk, that will change. All right, let's see. So, sorry, this screen is going really slow. The person who's portrayed in that movie, The Devil's Violinist, is the Italian violinist Niccolo Paganini, who is thought to be one of the first historical figures who likely had Ehlers-Danlos syndrome, which is a connective tissue disorder associated with hypermobility and abnormal collagen. He was really, really talented, and today there are things that he could do on the violin that people still can't replicate. And this is thought to be due to his really long fingers and flexible joints and wrists. And in fact, he was so talented that it was said that he must have sold his soul to the devil in order to be able to play like that, which is where the name came from and where the theme of the movie came from. Officially, though, the first actual person to be diagnosed with Ehlers-Danlos syndrome, that diagnosis came from two French physicians, and it was in 1901. And that's really where this idea of hypermobility has kind of taken off since then. But the truth is that people who are hypermobile are in a lot of ways kind of like X-Men. They have these superpowers where they can oftentimes do things that are not within the capabilities of humans who are not hypermobile. So a lot of times we'll see people who are hypermobile excel in sports like gymnastics and dance. These are pictures of a professional rhythmic gymnast and ballerina. This is a picture of Billie Eilish, who has hypermobile Ehlers-Danlos syndrome, and she's had the ability to do all kinds of contortion throughout her life. There's also pretty good evidence that Michael Phelps is hypermobile, which was thought maybe to be due to a diagnosis of Marfan's, which is, I think at this point, kind of been ruled out, but he is still definitely hypermobile, as you can really pretty clearly see in these pictures. And that's thought to be something that's really aided in his ability to excel in his sport. The problem is, though, is that with the superpower does come some trade-offs and some consequences. And one of those things is that hypermobility does absolutely seem to be associated with abnormal bleeding symptoms. And I'll even go so far as to say that we should start considering hypermobility as a bleeding disorder in and of itself, or at the very least, a subtype of people who have bleeding of unknown cause. Because it is really something that is contributing to symptoms and a lot of times can explain things when otherwise there is no other explanation. So this has been pretty clearly demonstrated in a number of cases. Let's see, that there has been for a long time plenty of evidence that has connected hypermobility to abnormal bleeding symptoms. That's been demonstrated in multiple studies. And the type of bleeding is pretty varied. The picture that you're seeing down here on the left is called the Rumpel-Lead sign, which is what occurs if you inflate a blood pressure cuff on someone's arm, and it causes all of these diffuse petechiae. But they can also have levita reticularis, really terrible mucocutaneous bleeding, and even intra-abdominal bleeding, although that is more often a result of like ruptured arterial aneurysms that can cause like say intraperitoneal and intrapulmonary hemorrhage. And the other thing that is kind of really worth noting is that a lot of people out in the community are hypermobile. Like say, if you start looking for these, you're going to be astonished at how many people meet the criteria, which I'll be covering in a little bit. It's estimated that up to 40% of females. So that's like say likely an underestimate just because this isn't something that we're really screening a lot of patients for. In the Spots and Dots clinic, when we looked at all of the patients who have what we call bleeding of unknown cause, which means that they have abnormal bleeding symptoms, but we can't find another underlying explanation when we do laboratory-based studies. A quarter of those patients are found to have generalized joint hypermobility. And we suspect that they probably have like a really unique overall phenotype and a unique set of clinical symptoms. And this has been shown in other institutions as well. In this study, they looked at all patients who came in with a diagnosis of bleeding of unknown cause and measured their thumb flexibility. So in other words, how far could their thumb go when they tried to get it to touch their forearm? And what they found was that patients who had bleeding of unknown cause were much more likely to have larger degrees of thumb flexibility when compared to mothers of those patients and when compared to controls in the general population. Now you might think, well, maybe that's just something that we see in patients with all different types of bleeding disorders, but when that same group also looked at other individuals from within the Hemophilia and Thrombosis Center that didn't have a diagnosis of bleeding of unknown cause, they did not see the same degree of thumb flexibility in those other bleeding disorders, including hemophilia, von Willebrand disease, and patients with other hemostatic abnormalities. But what's the connection here? It may not seem automatically intuitive that someone who has flexible joints would necessarily have abnormal bleeding symptoms. And the answer to that question is collagen. So that's really what I'm going to be talking about today. I'm going to be talking about collagen and all of the fascinating ways that it influences hemostasis and a lot of other processes in the body. I'm going to be talking about how patients with collagen disorders, how they bleed, and what the syndromes are that are associated with abnormal collagen dysfunction. So collagen is, believe it or not, the most abundant protein in the body. It accounts for 30% of our total body mass. There are 29 different types, but by far and away the most of those are made up by types 1, 2, 3, and 4 collagen, and a little bit of type 6 as well. There's 2 different types, and the types are really important to their overall function. There are fibrous or fibrillar and non-fibrous or non-fibrillar types of collagen. The most common are the fibrous types, which includes types 1, 2, 3, 5, and 6. In these cases, while all collagen kind of has this amino acid background and that these like long chains eventually get packaged into this kind of triple helix, a lot like DNA. In the fibrous types, those chains all get kind of bundled together in one fibril and then a bigger fiber, kind of a lot like a muscle. So type 1 is really the most common type. It makes up about 60% of the total collagen in the body. And type 5 is very strongly associated with type 1. It's really important for generation of new type 1 fibers. And type together with type 3, types 1, 3, and 5 all really exist in the basement membrane of all tissues within our body. Types 2 and 6 are much more common in like cartilage type tissue. And type 3 is again very, very prevalent in any deformable tissue, including the basement membrane. Now, the non-fibrous types is mostly type 4 collagen. And what happens in these cases is you get that amino acid backbone that gets packaged into a triple helix. But then the bonds at the end of these alpha chains allow for this different kind of configuration that's referred to as sort of like a chicken wire network that makes it much more structural and kind of scaffolding in shape. So collagen is, I think, really underestimated as a mediator of health and disease, because if you think about it, it's present absolutely throughout our body in all different tissue types, including around vessels, joints, nerves, basically in all of the in-between scaffolding spaces. So if this is a blood vessel here, the space underneath it is the basement membrane, and you can see that a lot of it is really taken up by collagen that kind of scaffolds and holds open that space where all of the other basement membrane proteins can kind of coexist within it. Collagen is actually made in the fibroblasts that sit at the very bottom of the basement membrane. And within the fibroblasts, most of the cellular proteins, most of the collagen protein is actually made within the cell itself. So there are many different types of collagen genes, and that is one area where you can have abnormal collagen synthesis is if there's a natural defect in the gene that impacts the structure and configuration of that collagen protein. But there are a lot of other places along the way where you can have abnormalities in collagen synthesis and function that can lead to ultimately dysfunction of that scaffolding space. So once the cellular protein is put together, it's moved into the extracellular space where it's then interacts with other types of proteins to basically be reconfigured into a structure that can interact with other either collagen, fibrils, or other proteins in the basement membrane. So ADAMTS2 and bone morphogenetic protein are both things that have this modifying effect on the protein once it's in the extracellular space. And so defect in the either collagen or these proteins can interfere with that ability to have that post cellular modification. Additionally, after the collagen protein is synthesized, it interacts with other basement membrane proteins like fibronectin, integrin, tenacin, also chondroitin. And if there are defects in any of these other proteins or a defect in the collagen's ability to interact with them, then again, you can have dysfunctional lying down of the collagen in this basement space. And whenever there isn't kind of optimal structure and filling in of collagen in this space, the body lays down elastic fibers in their place, which explains why patients who have defective collagen often will be more elastic. So the elasticity is kind of almost like a marker, a surrogate marker for there not being really effective good structural integrity of the collagen, whether that's, the types 1, 3, and 4 fibrillar, or that kind of chicken wire scaffolding of the type 4 collagen. And because connective tissue is so ubiquitous in the body, because collagen lays down in, like, say, almost all of our tissues, it really is not surprising that we can see different manifestations in multiple organ systems of abnormal collagen. This is kind of a good description of that. You can get various craniofacial features, abnormalities in pulmonary tissue, a lot of cardiac defects, a lot of musculoskeletal abnormalities, and also abnormalities of the hollow viscus of the abdomen. Some of the things that you really might not have thought that collagen could play a role in, certainly I didn't until I started looking into this, and I think this is still an area of really active novel research, is collagen plays a role in immunoinflammation, and that isn't really fully understood, but it's thought to have something to do with the way that different immune cells sort of roll along the endothelial surface of the blood vessel and can sometimes interact with that sub-basement membrane collagen. In this interesting study done in outpatients with COVID-19 infection, they injected a blinded group with polymerase type 1 collagen and found that those patients had statistically significant improvement in their clinical symptoms, as well as decreased inflammatory cytokines, and ultimately improved much more quickly as well. We also know that collagen likely plays a role in the invasion and metastatic capability of a lot of types of cancer, which is not too surprising, again, since that collagen kind of lives just right underneath that endothelial surface. It's thought that the initial stages of invasiveness of a carcinoma in through that endothelial space can even sometimes be modified by collagen itself if there are signaling in between the cancer cells and the subbasement membrane, signals that allow that collagen to sort of fall apart or reconfigure itself that makes it easier for the cancer to invade. Also, it's thought that this can impact angiogenesis and the ability for that carcinoma to also further metastasize. So that's a very active and exciting area of research that's really ongoing for solid cancers. But moving into bleeding symptoms, what is the connection between collagen and abnormal hemostasis? Well, the answer to that question really starts with von Willebrand and platelets, the very beginning of hemostasis. So what this picture is trying to demonstrate here is you have to kind of imagine that the endothelial surface of cells, that layer of the blood vessel wall is kind of right in between this invisible space here. And when you have some kind of denudation of that endothelial surface, you then have exposure of collagen to circulating blood cells, as well as exposure to von Willebrand factor, which is sort of the initiating phase of this interaction. So the first thing that happens is von Willebrand factor in the alpha 3 domain will bind to type 1 and 3 collagen. And so if you don't have a good binding there, then the rest of hemostasis, the rest of platelet adhesion and activation can basically fall apart even as quickly as that. You have to have a really good bond here, and the higher the molecular weight of that von Willebrand, the more tightly it's going to bind to type 1 and 3 collagen. Only once that happens do the platelets, are the platelets able to sort of roll along that collagen surface. And eventually what's going to happen then is that rolling process is going to connect this alpha 2 beta 1 glycoprotein on the cell of the platelet to interact with type 4 collagen. And once that happens, that really anchors down the platelet to the collagen surface via von Willebrand and this other alpha 2 beta 1 protein. Only once that platelet is really strongly adhered to and anchored to collagen is glycoprotein 6 on the platelet surface able to interact again with types 1 and 3 collagen. And that's the key step that allows for platelet activation on the collagen surface. Once platelets are activated, they release these intracellular mediators like thromboxane, ADP, fibrinogen, that allows other platelets to then attach and themselves activate and kind of expands the platelet plug. It also inverts the cellular wall on the platelet, so it exposes the negatively charged phosphatidylserine that's usually on the inside of the platelet wall to the outside surface, which allows for the coagulation cascade to propagate and generate thrombin and ultimately fibrin that lays down that kind of fibrin mesh on top of the platelet plug to really solidify a platelet clot. This interaction of platelets with collagen also allows for platelet microvesicles to be released, which are known to be very thrombogenic and important in hemostasis and sometimes pathologic thrombosis as well. So it's really interesting that, the collagen is actually such an integral part of primary hemostasis in particular. And to be perfectly honest, this wasn't really something that I really had in my mind as part of the the physiology of thrombosis and hemostasis until just recently when I started kind of investigating this a little bit more. Collagen's kind of always been there in the background. And I think, like say, we really just haven't given it much attention and really not realized how much of a role it plays in hemostasis, but a lot of other disease processes as well. At this point, I know there are even some ongoing studies right now, mostly in mice, even looking at some of these interactions as potential targets for drugs that can maybe be advantageous. In other words, anticoagulants that maybe will decrease the hemostatic potential during, surgery or central line placement or whatever it may be, but maybe not escalate the bleeding risk as much as some of the current anticoagulants that we have available. Although that's all definitely still a lot, very much in progress and not actively available. So there's a lot, if you go through the literature and kind of look and try to find out, well, why do patients with Ehlers-Danlos syndrome and other connective tissue disorders and hypermobility have abnormal bleeding symptoms? One of the most common things that'll come up is that these disorders appear to be associated with platelet dysfunction. And that's demonstrated here in a couple of studies. This first study is done in patients with vascular type EDS, where they found that some patients had both abnormal bleeding time and abnormal platelet aggregation. Those are the patients that are represented in red here. But you can see there are plenty of patients on this line here with the little blue dots, and even below that who had totally normal or even decreased platelet aggregation or increased platelet aggregation, indicating that this is really not a consistent finding across all patients with hypermobility and other connective tissue and collagen vascular disorders. This is another study that kind of looked at the same thing. They looked at 3 different EDS subtypes, all of which I'll kind of get into a little bit more. But these are all conditions that are associated with hypermobility. And what they found was that patients with both classic hypermobile and vascular type, when they looked at all of these 3 different subtypes of EDS, at least one platelet function abnormality was found in almost 90% of these patients across the board, 79% in hypermobile and 85% in vascular subtype. And yet another study also showed that in a prospective evaluation of patients with hypermobility, that at least 47%, so almost half patients had platelet abnormalities. So this is definitely a really consistent finding, but not something that I think intuitively makes a lot of sense when the problem is thought to be collagen. But one theory that has been thrown out, one that makes a lot of sense to me, but definitely not one that is fully fleshed out, and I don't think we really have a great understanding of yet. But it's thought that the reason why we see these platelet abnormalities is not because of the platelets themselves, but more so because the platelets that we are looking at have interacted with this dysfunctional collagen and then sometimes been partially turned on or partially activated, but we're not able to stay adhered to that dysfunctional collagen, and so then end up circulating around the blood where they can be collected and analyzed by platelet studies. And when those platelets are challenged in the lab, they don't activate, they don't turn on, they don't secrete, they don't aggregate in the way that they're supposed to, because they've been sort of contaminated and exhausted by their previous interaction with this dysfunctional collagen. And even though this study that I'm going to show you is very small and quite old, I think that it demonstrates that theory really well. What happened was they took 2 patients who were known to have classical EDS and abnormal bleeding symptoms, and they took their collagen and exposed it to normal patients' platelets and performed a platelet aggregation test with normal platelets and this abnormal collagen. And what they found was that in both cases, the platelets aggregated less well than they did to normal collagen. Following that, they took patient 2, the case 2, and they took that patient's platelets, and then they exposed it to both normal and the patient's collagen. And again, found that when they took those platelets and exposed them back to normal collagen, the platelet aggregation defects totally corrected, whereas they persisted when they used the patient's collagen itself. In other words, in both of these phases of the study, the platelets stayed the same, but the collagen changed. And that's where you saw the decreased aggregation, the decreased platelet function, apparent decreased platelet function, leading to the theory that, like say, the problem in collagen disorders and hypermobility is not so much the platelets, but really the collagen. However, I do want to make the caveat that sometimes it might be both. And this study looked at patients not necessarily with platelet dysfunction, but with von Willebrand disease. And what they found was that patients with von Willebrand disease, even just mild type 1 with mildly low levels, oftentimes had really moderate or severe bleeding phenotypes with a lot of perioperative hemorrhage, heavy menstrual bleeding that required transfusion, and other significant bleeding symptoms. And the thought was that these patients that were hypermobile, who also had these other mild bleeding disorders, sort of had an exponential increase in their bleeding symptoms above what you would maybe expect with an otherwise mild bleeding disorder. So I think some of the discrepancy that we've seen in previous studies on people with collagen disorders and this apparent platelet dysfunction may really be due to a kind of the red herring of an apparent platelet dysfunction that's really actually due to the abnormal collagen. But sometimes I think patients may also have underlying platelet disorders as well. And I think that's sort of muddied the water and is an important thing as hematologists for us to keep in mind as well when we treat these patients. All right, so all of this is really to say that hypermobility, in other words, increased elasticity in tissue, whether that be skin or joints, that is really a surrogate marker for underlying collagen abnormality that may explain abnormal bleeding symptoms. We don't have a test that we can do that can really easily prove, through just a serum test that someone has abnormal collagen function. So we have to rely on clinical tools to evaluate for hypermobility and use that as a surrogate for investigating abnormal collagen function. And the way that we do that is with the Beighton score, which I think a lot of people have probably seen and are familiar with at this point. But it is out of a total of 9 points, and it asks you to try to touch your thumb to your forearm, bend your pinkies back. It looks for hyperextensibility at the elbows and the knees, and asks you to put your palms flat on the floor without bending your knees while bending over at the hip. And anything that is greater than 4 would be considered to be abnormal in a post-pubertal individual. And this all kind of needs to be taken with a grain of salt, because as patients have underlying hypermobility, that can lead to early joint damage and joint stiffening. And so we do have other tools that we can use to dive deeper when we think that's the case. But this is at least the starting point that I think is really important for all hematologists to know and be able to employ in their clinic in order to screen patients for hypermobility, again, as a surrogate for looking for collagen defects that might explain bleeding symptoms. Now, once hypermobility is identified, that really is kind of enough, like to say, okay, well, this might be something that can explain your symptoms, but it can also be just the first step in understanding a wider syndromic problem that might be affecting that patient. So over the years, there has been some evolution of the diagnostic criteria for Ehlers-Danlos syndrome, hypermobility, and all of these syndromes that are associated with joint hypermobility. Some of the different subcategories include asymptomatic, non-syndromic joint hypermobility. So this would be the patient that you see that you do a Beighton on and they meet criteria, but they have absolutely no symptoms, they have no pain, they're just as surprised as you are, and it's not negatively impacting their life in any way other than maybe contributing to some excess bruising and other mild bleeding symptoms. Those patients would fall into this asymptomatic category. If you have joint hypermobility, however, and as well as the syndromic features that go along with Ehlers-Danlos syndrome, such as musculoskeletal involvement, meaning like pain in multiple joints that persists over several months, systemic involvement, meaning other clinical features, whether that be skin elasticity or easy scarring and pronounced scars, or a family history, that would land you in the hypermobile or syndromic joint hypermobility subtype. And then if you have some of those features, but not quite enough to get a diagnosis of hypermobile EDS, then you fall into this hypermobility spectrum disorder, which is kind of a large bucket that I would say at this point, most of our patients are falling. So let's talk a little bit more about Ehlers-Danlos syndrome. I know I've mentioned that a lot, and if you haven't heard me talk or you haven't really explored this a lot in the past, you might feel overwhelmed by the diagnosis of EDS, because I think that this is particularly challenging patient population to manage because they do have so many systemic symptoms. And I think as a hematologist, kind of knowing even where to begin and kind of where do I fit in and helping to manage these patients can be really, really overwhelming. What I would recommend doing is these are the 13 different subtypes of Ehlers-Danlos syndrome. Um, and most of these can actually be kind of not ignored, but definitely not memorized by the hematologist. I don't think they're super relevant for our practice because they're really more very rare, more so presented in like case series and not necessarily things that we're likely to see in our clinic, at least with any type of frequency. So I would say these ones that I've put into brown, you can almost like say, just kind of know they exist, but not have to remember the details about them. In many cases, these really aren't even associated with hypermobility or necessarily bleeding symptoms that prominently either. Similarly, these other achalasia, dermatospraxis, and kyphoscoliotic are a little bit more common than these ones in brown, but definitely, again, not common enough, I think, to prioritize in your memory when you're trying to think about Ehlers-Danlos syndrome patients. More so, these top four are the most common and the ones that you're most likely to encounter, where you, I think, as a hematologist, might have an ability to intervene and make a difference in these patients' life, potentially even in a life-saving fashion. So classical and classical-like EDS are very similar. They're both associated with this COL5A1 mutation, sometimes COL1A1 and tenascin mutations. Hypermobile EDS is the type that we're probably seeing most common. That's associated with joint hypermobility and not necessarily one particular gene abnormality. It's the only one of the 13 where that's the case for. And then, of course, vascular EDS is also worth mentioning, even though it is much rarer, only about 4 to 5% of total EDS cases. It is probably the one that's associated with the most potentially life-threatening abnormalities, and it's important to be able to identify those patients so that we can refer them for the appropriate screening that, again, could be potentially really important to prevent catastrophic events in these patients. So a lot of patients with EDS of various subtypes, but particularly the classical and hypermobile subtype, will have elastic skin tissue. So this is something to think about when you're evaluating patients that you see have really hypermobile joints. If you're doing this and you're investigating it, it's important to know like what exactly is increased skin elasticity. I think that sometimes I can even pull on my own skin and think, hey, that seems like that's stretching really far, and it's hard to know like what really is abnormal until you've seen it. But I really think that these pictures kind of explain it well. This is someone who has normal skin elasticity, normal collagen, and these are patients with classical EDS who have increased skin elasticity. And I think you can really kind of see the difference. The way I would describe it is in someone who has normal intact functional collagen, the skin is going to be trying to pull itself back and try to retract when you extend it. However, people with classical EDS tend to just, their skin kind of is like, okay, well, let's go. It just doesn't really seem like it's going to even try to bounce back. You can really stretch it much, much further without that kind of reverse tension. Some sites where this is easily demonstrated is over the surface of the hand, on the chest. This is easier because there's not a lot of like subcutaneous fat in those areas. If you try to do it over an area where there is more subcutaneous tissue, it might not be as pronounced, which you can kind of see in this picture, but the skin there may still seem like very doughy. And so, yeah, this is kind of an example of what you would expect to see. The technical definition is like 2 centimeters of stretch, but I think that's kind of impractical, and it's really more of just like a kind of a gestalt, you know it when you see it. Other features that are commonly seen in across various different subtypes are these epicanthal folds, really, really pronounced striae. Patients get these cigarette paper, atrophic, or papyrus like scars that are often over extensor surfaces like the knees and the elbows, and sometimes they'll be hemocytoritic and sometimes associated with these like molluscoid tumors. Their skin is often very translucent, where you can see these like blue blood vessels kind of peeking through. These are called pisogenic papules that are often associated with all different subtypes and are found on the heels. And then patients oftentimes will also be found to have a high arched palate. I shouldn't say often, but these are all features that are strong indicators that a patient may have an underlying collagen vascular disorder, but it's definitely not seen in all cases. So I'm going to kind of brush through these since we lost a little bit of time. I talked a little bit about classical EDS. These are the major and minor diagnostic criteria for that, but I want to spend a little bit more time on vascular EDS. The major diagnostic criteria here are really arterial or hollow viscous rupture, which is the defining feature of this disorder. It was a really shocking study to come across. It looked at 26 patients and 105 family members that had known vascular EDS, and then looked at the cause of death in all of those patients. And in 126 of them, the cause of death was either arterial rupture, organ rupture, or gastrointestinal rupture. So this is the way that most of these patients die. These are the kind of classic features. They have, like, say, that thin translucent skin. They often have like a very thin philtrum. They have a broader nose. They may have attached earlobes. So instead of like having a little lobe, their ear kind of just like directly connects. These epicanthal fold, they're called like almond shaped eyes, really deep set eyes. And being able to identify a patient with these clinical features combined with a mild bleeding phenotype, could be something that allows them to get the diagnosis that gets them the screening needed to prevent a catastrophic event like an arterial rupture if they're found to have an aneurysm. It should be noted too that pregnancies are very dangerous in this group. 12 out of 81 in a meta-analysis, pregnancies were associated with maternal death, though that probably is a little bit overestimated because a lot of patients that have perfectly successful pregnancies don't get written up in case reports. But hypermobile subtype is definitely the one that we're seeing the most often. And this patient population can be really challenging again because they don't have a gene that can really prove that they have this diagnosis. And a lot of the symptoms that they have can overlap with other connective tissue disorders or other musculoskeletal disorders. These patients also tend to have a predominance of non-inflammatory type pain, psychiatric and behavioral health symptoms, fatigue, difficulty sleeping, depression, and a lot of musculoskeletal dysfunction as well. And I think it's really difficult too because these patients often aren't given a diagnosis until very late in their life. And so there is an innate kind of fractured relationship between the patient with hypermobile EDS and the medical system in a lot of cases that further makes it challenging to really optimally care for and improve these patients' lives. There are other collagen vascular disorders that are also associated with mild abnormal bleeding symptoms. But for the sake of time, I'll kind of just brush through them for right now. And then in terms of other things that we can do to try to make a diagnosis when we find a patient that has hypermobility and we suspect an underlying syndrome, is really molecular investigation is really kind of the only other option, but that is something that's becoming, I think, more and more commonly employed are these multi-gene panels that can look at several genes simultaneously. Invitae has a really good one that looks for all the different EDS genes. And there are some other panels as well that can look for other syndromes that are associated with hypermobility, even if it's not EDS. So this is an example of one of those panels. I will say that at the current time, I don't know that I've seen anyone have like a known pathogenic mutation come back. We've had a lot of patients have these kind of variant of unknown significance and known potentially pathogenic genes, but I think that there's still a need to have a lot more of these tests done before we really truly understand the population prevalence and know which genes are pathogenic and which ones are not. But it is still really helpful if you have a patient with the appropriate clinical phenotype that matches up with an impacted gene. I think it really can lend credence to a suspected diagnosis of EDS or other collagen disorder in hypermobile patients. All right, so when it comes to the hematologist's role in this, where do we all fit in? This was a really good study that was done across HTCs, and they asked all of the hemostasis providers in particular a bunch of questions about managing hypermobile patients. And one of the most interesting things to me was that every single provider said, yes, I'm aware that hypermobility is associated with abnormal bleeding symptoms, but only 2/3 were consistently screening patients for hypermobility. And the reason for that was, there's not really a lot of good treatment options if you do identify someone. There's not really good functional tests to confirm a diagnosis, and it can be very time consuming if you're trying to work your way through all of the different diagnostic criteria. Um, but on the other hand, over half of hemostasis providers admitted that if they do identify joint hypermobility, that it would impact the way that they make like a surgical plan for someone who otherwise just had bleeding of unknown cause. Also interesting is these patients don't really have one particular medical home. I would say most of the patients, this is kind of consistent with what we practice here at University and Children's, is they end up in a genetics clinic. I don't really understand how rheumatology ends up as a medical home. That actually makes less sense even than hematology to me personally, even though I do understand there's a lot of musculoskeletal symptom and sometimes, mast cell activation, other autoimmune symptom overlap. But apparently that's something that is seen across the country at other HTCs. And hematology is this little tiny sliver here, 3%. And I think this is really important to point out because in my opinion is that it's not the role of the hematologist to holistically manage these patients with their multiple different symptomatic complaints affecting multiple different organ systems. I just don't really think that we have the appropriate training to be able to do that. But I do think because these patients often will present with bleeding symptoms, heavy menstrual bleeding, bruising, uh, or bleeding with minor wounds, gum bleeding, whatever it may be, the hematologist might be the first medical professional that these patients show up to. And so it is really important that we know how to do a basic screening for hypermobility to explain their symptoms, but also have a basic understanding of who the high-risk patients are that require further referral on to a geneticist or another medical provider to kind of further complete the workup, identify what the true underlying diagnosis is beyond hypermobility, and help to kind of triage all of the different multidisciplinary team members that should be involved in their care. What can a hematologist do, especially for bleeding symptoms when these patients are identified? The best studied medication is DDAVP. In one study, they did bleeding time. This was kind of a long time ago when they used to actually do kind of like the skin scraping and actually test how long it took for patients to stop bleeding. Not something that we do very often anymore. But for patients who had Ehlers-Danlos syndrome and abnormal bleeding symptoms, they did a pre and post DDAVP trial on these patients and did find that they had a statistically significant improvement in their bleeding time. And in that same study, clinically looked at those patients using prophylaxis around the time of surgery with DDAVP. And when they did so, found that none of the patients were reported to have excess bleeding, but when no prophylaxis with DDAVP was used in these patients with EDS, there was a bleeding rate of 30%. That was not statistically significant, but obviously, like say, a really small study. And the way that this is thought to really improve bleeding symptoms is primarily through increasing von Willebrand factor protein and really mostly increasing those high molecular weight proteins, which are much more able to bind to type 1 and 3 collagen and can probably overcome to some degree that defect there if you're really increasing those high molecular weight multimers enough. Another medication that is used commonly is tranexamic acid. In that same study where they surveyed hemostasis provider, antifibrinolytics were by far and away the most commonly used hemostatic agent around the time of surgery for these patients, even more so than DDAVP, which is interesting because outside of this particular survey, there's no other studies in terms of efficacy in patients with hypermobility or Ehlers-Danlos syndrome, but it is something that we use a lot for patients who have abnormal bleeding symptoms with and without underlying bleeding disorders. So it certainly does make a lot of sense and has really good, just I think, anecdotal support, even if it doesn't have good evidence-based support. Another thing to consider, especially for bruising symptoms that are bothersome to patient, is ascorbic acid, which in patients with hypermobility has been shown to have a negative correlation so ascorbic acid has had a negative correlation between levels and the ISTH BAT, indicating people with higher ascorbic acid levels have lower bleeding symptoms. And there's also been some studies in patients with hypermobility and EDS where ascorbic acid supplementation was associated with improved bleeding time, better wound healing, and even in one study, improved muscle strength. And the way that this is thought to really occur is that the ascorbic acid increases something called lysyl hydroxylase in fibroblasts, which increases collagen synthesis. And in EDS patients, that has been shown to even be like twofold over baseline. So this has not really been something that has shown statistically significant improvement in patients with EDS, but it's a pretty low risk intervention and something that patients can try. Sometimes it's nice to have something to try when there aren't a lot of other good proven options. Another thing that I personally recommend that is not really included in the EDS literature necessarily is arnica. There are some studies that have shown that arnica, which is like a flower-based natural product that has essentially no side effects, especially when used just topically, has an improvement, it has shown an improvement in resolution of edema and bruising, as well as in some studies, even like pain after surgeries. It's used a lot in Europe and in Germany where it's approved, but it has not been FDA approved as of now in the United States, because a lot of the studies are contradictory and not really well designed. But again, this is something that can be just used topically that has essentially no side effects. And the way that it is thought to work is via decreased release of serotonin and prostaglandins, thromboxane from activated platelets, which prevents that like edema and decreases increased platelet aggregation. So the last thing is recombinant factor 7A has been used in patients with vascular type EDS, but this is not something that you would really go for and except in cases of life-threatening bleeding. Again, in vascular EDS, there's really thought to be less of a hemostatic defect, and more so these patients are predisposed to formation of arterial aneurysms that can then rupture and obviously be very quickly life-threatening. And so in those cases, recombinant 7A may be beneficial, just as in any, like massive blood transfusion protocol would be also appropriate in these patients. I would not recommend using recombinant 7A for other patients with hypermobility or collagen defects outside of those kind of life-threatening scenarios. The last thing that one may think would be helpful is collagen supplementation. You can get collagen in like gummy form and powders and liquids, and they're really, I think, heavily advocated for in like social media these days. But the truth is that a lot of the touted health effects have not been rigorously tested in good randomized trials. And so it's not something that has ever been, as far as I know, studied in patients with EDS. I went to a conference once where I could have sworn an expert say that it had been studied and is not beneficial. But when I have looked in the literature, I can't even find any studies whatsoever. So at this point in time, it's not something that's being recommended for patients with collagen disorders, hypermobility, or EDS. These patients are at really high risk, obviously, for surgical complications. This is an example of a treatment plan that we made for a patient who was undergoing a hip surgery. This was a patient who definitely had hypermobility, was suspected to possibly have hypermobile EDS, but also had some abnormal platelet aggregation tests. And again, because of this kind of lack of clarity of whether or not that patient could also have a separate platelet disorder, or if it's just related to exhaustion from interaction with abnormal collagen, we did kind of consider that both may be possible and recommended that this patient receive DDAVP and TXA up front, but then also had a platelet or platelets on hand just in case there was any excess bleeding. I think a really important thing to emphasize is that in the creation of this, we actually did a multidisciplinary Zoom meeting with like myself and the surgeon and the anesthesiologist and the surgical nurse, just to kind of all get on the same page and kind of share ideas and thoughts of how to best take care of these patients, just because they can have, a lot of unforeseen complications around the time of surgery. They obviously have trouble healing wounds. And so doing things like redundant sutures is really important. The anesthesia component is important because they might have issues with cervical instability. And so taking care of placement of the neck is really important. Sometimes they're sensitive to tape. And so the tape that they put around the eyes may need to be considered. All of these things are, really patient to patient and may not affect everyone, but are things to kind of take into consideration for all patients with not just hypermobility, but with a true like syndromic EDS or other underlying collagen disorder. If possible, it's always better to avoid procedures in these patients, especially those with vascular type EDS, especially if there's another alternative like ultrasound that can be done in its place, in place of like a diagnostic intervention, like an angiography or something like that. Other things to consider in patients with EDS who have a uterus, these patients do tend to have a higher frequency of dysmenorrhea and heavy menstrual bleeding, and also have been shown to have a lot more kind of overall well-being dysfunction, greater impact in school and work, and in like multiple aspects of quality of life other than what we might see in patients with von Willebrand disease who have heavy menstrual bleeding, for example. So that was demonstrated in the study where they looked at a young women's clinic, kind of similar to the Spots and Dots clinic, and interestingly found like a very similar proportion of patients that had sort of bleeding of unknown cause who had hypermobility. And 80% of those patients showed limitations in work or school. They also were more likely to be anemic and more likely to be refractory to first-line heavy menstrual bleeding symptoms. But interestingly, a lot of these patients did also express or report that they had participated in some sort of sport that you would maybe imagine someone who's hypermobile would excel in, like gymnastics and cheer. So that's something that we do see quite a lot as well. And then pregnancy. Again, I had kind of mentioned this with the vascular subtype, but even with other types of Ehlers-Danlos syndrome, there does seem to be more postpartum hemorrhage and more bleeding during pregnancy as well. So it's important to, as a hematologist, be involved with patients who have Ehlers-Danlos syndrome, even if it's just for monitoring and to counsel on available options such as use of tranexamic acid when appropriate. When it comes to pregnancies in the vascular subtype, it's definitely not completely contraindicated, but something that should really strongly be discussed before in all ideal scenarios. And for patients who are pregnant, it's important to make sure that they're getting routine screening with ultrasounds to look for evidence of arterial aneurysm formation, and to plan for an early C-section so that they don't have to go through labor, which would increase the risk of uterine rupture. These patients are at risk of arterial rupture even a couple of weeks after procedures or after delivery. So that's important to keep in mind. And when it comes to EDS as a whole, not just vascular subtype, it does not appear that neuraxial anesthesia is completely contraindicated. Of all of the available studies on this, only one spinal hematoma has been reported to date. Not that that is insignificant. I think we definitely need more studies there. But it's really important that these patients have a multidisciplinary team, as I previously mentioned. I will, just because I'm running out of time, kind of jump down here when it comes to other non-hematologic management. When it comes to pharmacotherapy, chronic pain management can be really challenging in these patients, and it's important that they have a team member who makes sure that they don't get stuck on long-term opioids, which has overall been shown to be detrimental. Exercise has really been the only thing that's been shown to be beneficial in preventing long-term pain in patients with hypermobility. And for patients with the vascular subtype, I do want to mention, just since this is such a commonly used medication, that fluoroquinolones have been shown to increase the risk for vascular rupture, and not just vascular EDS, but other types of aneurysms as well. So keep that in mind since we use that medication so often. I want to jump to the summary here. I still think that there's a lot more that we don't know than we do know about Ehlers-Danlos syndrome, hypermobility, and collagen disorders. I think it's really important that all patients with bleeding of unknown cause, if not every new patient who's coming in for assessment of abnormal bleeding symptoms, be screened at least for generalized joint hypermobility with a Beighton score. But not everyone with a abnormal Beighton score is necessarily pathologic, has EDS, or needs to be referred to a geneticist. I do think that everyone should have an echocardiogram, though, just to screen for potential cardiac aneurysms or aortic aneurysms or other cardiac abnormalities. When you do suspect that someone has other syndromic features, I think the next appropriate step is to refer them on to genetics, but also making sure that they get plugged in with a physical therapist and a behavioral health expert to address the joint needs, and sometimes also depression, anxiety, and other psychological effects that can come along with this diagnosis. And then consider that patients may have multiple diagnoses. That's important too. Don't just anchor onto EDS and overlook the fact that they may also have a true platelet disorder, von Willebrand disease, or factor deficiency. And to make sure that these patients get the same kind of hematology support during surgery and pregnancy. So thank you very much for listening to this. I do think that this is a group of patients that I think a lot of times becomes very stigmatized and is at risk for not only poor bleeding outcomes, but just overall poor quality of life because of the stigmatizing symptoms of chronic pain, heavy menstrual bleeding, and just overall carrying an invisible diagnosis, especially patients with hypermobile EDS. So as hematologists, since we're seeing these patients, we have an opportunity to identify them, to not only offer them appropriate hemostatic therapies and support, but also just to make sure that they're getting plugged in with the other appropriate services and get the care that they need. My goal moving forward is that we'll have easier tools for non-geneticists, including hematologists, primary care physician, gynecologists, to be able to more easily and efficiently identify these patients and kind of a protocol of what to do when we do identify them. Of course, also better studies to know how to prevent and treat bleeding when that does occur. I apologize for taking longer than intended and for the technical difficulties, but definitely happy to stick around and answer questions as long as anyone else is willing to stay.
Thank you so much, Jenna, for that really comprehensive discussion of what is collagen and why should we care. So thanks very much. We do have several questions, and I'll just throw some out, and we'll see how far people can hang on. So the most recent one, any thoughts about treating abdominal wall bleeding during pregnancy as the abdomen becomes more distended, and is tranexamic acid safe during pregnancy?
Yeah, absolutely. So to answer the second question, because I think I can be more confident in answering that, there is not actual safety data for tranexamic acid during pregnancy per se. However, it is, I think, considered to be like a class C. Is that the one where it's like the benefits will often outweigh the risks? And I will say anecdotally, it is something that we definitely used and we use very often for patients with other inherited bleeding disorders. And I'm not aware of any report, either anecdotally or in the literature, of any adverse outcomes associated with tranexamic acid use, either during pregnancy or during breastfeeding. So I would say that would be an appropriate thing to reach for these patients, like say, but there is no studies at all for EDS patients or hypermobile patients or collagen disorder patients when it comes to tranexamic acid. It's just really something that we reach for in all cases of abdominal bleeding symptoms of any kind. When it comes to the abdominal wall bleeding, I can't say that that's something that I've had a lot of experience with personally or have come across when I've been looking through what literature exists. I could see that being more of an issue. And I would say if someone is having that type of bleeding, I would also investigate whether or not they have, one of these more severe subtypes, like a vascular type EDS, just because that would be more than I would expect to see from someone with just hypermobile subtype, and you'd want to potentially consider those patients for other type of screening to make sure that they don't have, like say, another underlying finding that could be really more dangerous once they go into labor or after labor. I'm not sure that really answers the question, but I think it's one of those areas that's just not really well known.
It's a super challenging situation. One comment from Dr. Santucci is that when proteins are ingested orally, they are digested in the stomach, and so supplemental collagen that way probably just gets digested to its amino acid forms. So another question, maybe a related one, is EDS typically de novo, or is it always inherited with all these different variants? How much is known about that? And also, whom do you send genetic testing? How do you know when that's going to be something to push for?
Yeah, really good question. So I don't know the frequency of de novo versus inherited, but family history is often considered to be part of either like the major or minor criteria for the EDS symptoms. And so if you do have certainly like a known family member, or all three other brothers are also jointed and hypermobile, I definitely think that increases the clinical suspicion and would certainly be a scenario where you'd want that family to see a geneticist. Otherwise, I think that this is something that really needs to be better delineated, especially for the hematologist. My personal practice is if someone is hypermobile, the very first visit I send them for an echocardiogram. And then when I see them back in clinic, which I try to do within the first 3 months, I'll go through some of those other secondary criteria and do a more detailed physical exam, look for some of these kind of classic physical findings. And if I see anything there, or through a family history, get more of a suspicion for an underlying syndrome, that would be the point at which I would send someone to a geneticist. I personally have only, I think in one case, actually worked with our genetic counselor at the Hemophilia and Thrombosis Center to send off a genetic panel kind of ourselves before they see a geneticist for evaluation. Mostly because I don't think that we really have the expertise in this to know what the right tests are to send. And because most of the time these patients have hypermobile subtype in which we wouldn't expect to find an underlying genetic defect. So I think it's okay to keep a low threshold if you're not sure. Yeah, I would say that it's not something that I personally do on my own very often, even though if I would, I have found that Invitae panel to be beneficial when I've seen other people order it. And Courtney Santucci is putting some really great comments in here. She's saying generally it's autosomal dominant, including the pattern we see with hypermobile types, so 90% of patients. So yeah, when we're seeing it within family members, that most of them, I guess you're saying, do have like another family member and would be considered to be inherited. And you can absolutely refer to genetics. There is a separate intake pathway for patients referred for hypermobility concerns. So that's really good to know too. Especially, I don't know how many pediatricians are on the call, but the special care clinic at Children's is a wonderful multidisciplinary clinic for patients with Ehlers-Danlos syndrome and other collagen disorders. It is a really great resource that I wish we had comparable in the adult side.
All right, I think so. We're 8 minutes past the hour, so I think we'll wrap it up there. But very super interesting topic, and thanks again for the great overview, and thanks to everybody for attending and asking wonderful questions. And hope everybody enjoys the rest of their week.
Yes, thank you all for hanging in there with me. Take care.